talk about, you mentioned it's diverticulosis that is the disease, and the complications are infection and then lower GI bleeding. I think it's accepted now that diverticulosis is the most common cause of lower GI bleeding. And in the doctor books, again, colonoscopy is said to be able to identify a site of bleeding in about 85% if done in the acute setting. Do you agree with that?
I have read that literature. It always seems very optimistic. I have found oftentimes if they're actively bleeding, there's so much blood that it's very hard to tell what's going on. So I just have not had that level of success. I mean, I think what the colonoscopy does tell us is if they find a tumor or whatnot, but I just have not seen that kind of level of success with diverticular bleeding, quite honestly.
And the other thing that's changed since CSAP 16 is that CTA seems to have become the test that we use to identify a site of bleeding in lower GI bleeding cases. Is that true at your institution?
Yeah, it really has become the test of choice. The three tests that we still have in our kind of little pocketbook of tests would be the nuclear medicine test, which is probably the most sensitive for bleeding, but unfortunately sometimes is a little bit, can't really localize it as well as we would like. Then we have, in angiography, mesenteric angiography, but that's fairly invasive. And so CTA seems to kind of negotiate the middle ground a bit, where we actually have better localization when it's positive. And therefore, I completely agree that has become our procedure of choice or our imaging of choice.
Since most of these bleeds stop, let's say you have a healthy 60-year-old who bleeds, you diagnose that it's most likely diverticulosis. It's a pretty straightforward case. You've got a bleeding site that you've identified, but they've stopped, and the patient rebleeds. Do you go straight to the operating room, or do you start the evaluation all over? Great discussion at many of the committees.
Yeah, I think that's a challenging one. I think it depends a little bit on how quickly they rebleed. If somebody has a bleed and we think we've localized it and, a year later they come back with bleeding, then I start over again. If they literally bleed the next day and I'm confident that we have localized it, then I think it's totally reasonable to do a segmental resection of that circumstances. Now, I have to admit, I've been doing a lot of colorectal surgery for a long time. I can still count on one hand the number of operations I've done for diverticular bleeding. So it's pretty uncommon.
Yeah, I think you're right. I think especially as time has progressed, I remember, I'm a little older than you, Charles, so I can remember when going to the operating room for these patients was, we were almost forced to do it, and now it is really a rare event that and most of them stop, or we can manage them with other interventions, usually through our IR colleagues.
Yeah, so we do a lot of, wouldn't say a lot, but we do embolization when someone's actively bleeding and we can identify the site. I think the ischemia risk, which has always been touted to being roughly 10%, I think they've gotten much better than that, and that's been pretty rare. I don't think I've ever had to operate anybody for ischemia after they've embolized somebody. So I agree. I think we've got better tools than an operation at this point.
Well, let's start a little discussion about colon cancer, and I know this is a very generic question, but genetics in colon cancer seems to be cropping up in almost every discussion that I hear, at least. So can you give us a synopsis of what you think a general surgeon needs to know about the genetics in colon cancer today?
Probably the most important thing they need to know is what I think is becoming fairly universal is that our pathologists are now testing for the mismatch repair genes, or at least evidence of them. We have different ways of doing that, and we can elucidate that further. And what we're really trying to do is identify those families that might have Lynch syndrome. Historically, we have done that based on family history, which has not worked very well for a number of reasons. number one, families tend to be smaller now, and so family history may not be as evident. And then number two, which is a little bit sad but true, is that we're just not particularly good at elucidating family histories. And so the reality is that a lot of, while it's relatively uncommon, we were missing those families. So in order to better identify this high-risk group, there have now really kind of universal testing on all tumors, and certainly done on all of our tumors here, where you either do some immunohistochemistry testing for the proteins expressed by those genes, or some sort of microsatellite instability testing. And that's part of the path report. So you need to be able to interpret what those findings mean so that you can properly refer our patients. So I think the essence of that for the average kind of general surgeon is that we just have to really understand what those path reports mean and the significance of what the findings are, and making sure we do the proper referrals.
Now, you correct me if I'm wrong, but in the mismatch repair genes, if you identify those, that is usually means that there is an autosomal dominant inheritance pattern in that family. Is that a true statement?
So it's a little bit more complicated than that. There are really four kind of classic genes, if you will, and the most common pattern is actually not going to be Lynch syndrome. And I have to kind of look this up myself all the time. But the most common pattern, I think, is MLH1 and PMS2, and maybe don't quote me exactly on that. But if they are knocked out, they're both knocked out together. So if the protein is absent, still 75% of those patients are sporadic. And so the next thing they do, at least at our institution, is there's a reflex test for the BRAF mutation. And if that is positive, then that patient just has a sporadic microsatellite unstable tumor that is not going to have a propensity to be passed on in a genetic way. So that's really the key to this, is that you have to be able to, and that's the majority of the patients that will have a positive test. So the screening tool will be positive. They'll then get a BRAF testing, which will suggest it's sporadic. If they don't have that gene mutation, then they absolutely could have Lynch. And those patients then get referred to genetic testing, where they then do germline testing. It is also possible that the tumor itself could have a genetic alteration that looks like Lynch, but it's still not in the germline mutation. And that's why we actually, at the end of the day, have to have actual genetic testing.
Let's say you have a sporadic colon cancer, and you do a adequate resection, an R0 resection, and what's the follow-up that is now accepted for that patient?
I think you're alluding to endoscopic follow-up?
Yeah, endoscopic, as well as looking for, is there a reason to look for metastatic disease?
Yeah, so then we're going to obviously risk stratify these folks, so it'll depend a little bit on their stage. If you have a stage 1 colon cancer, which would be a T1 or T2, and there's no nodes, and you've done adequate nodal sampling, which I think in this day and age we consider to be at least 12 lymph nodes have been looked at, then that person would be considered low risk. It probably does not need any surveillance for metastatic disease ever, but they should get their endoscopic evaluation. Once you've been diagnosed with a colon cancer, you are now in the high-risk category. And so what I would do for all of our patients is they get a colonoscopy 1 year after their original surgery. If that's normal, they get one 3 years after that. If that's normal, every 5 years for the rest of their life. With regards to if you then have more advanced stages, so if you have a stage 2 colon cancer, that would be a T3 or T4 cancer with no nodes that are positive, then you still have about a 20% chance of developing metastatic disease. So those patients generally are referred to medical oncology. It gets a little bit complicated because they'll have a discussion about whether you're considered to be, quote-unquote, a high-risk stage 2 or a low-risk stage 2. In general, I would say the most evidence would suggest they don't need chemotherapy, but in some select high-risk stage 2s, they might get chemotherapy. But they probably do warrant surveillance because of that 20% recurrent risk. And those people will get CT scans at least once a year. They'll get their CEAs followed, 3 to 4 times per year. And if they identify metastatic disease, we can intervene earlier. Certainly our stage 3 colon cancers, which would be people with nodal disease, need to get chemotherapy, and then they would get active surveillance as well.
And the chemotherapy, has it evolved anymore?
It certainly has evolved since I was a resident, which was basically just 5-FU and leucovorin. We now still use mostly 5-FU-based chemotherapy, but they've added oxaliplatinum. So the standard now is really what we would call FOLFOX, which is oxaliplatin, 5-FU, and leucovorin. I do believe that has kind of fundamentally changed the way we think about colon cancer because the chemotherapy is much better. There are certainly other agents that we use in the metastatic disease, which would include irinotecan. Now there's Avastin, for metastatic disease as well. The bottom line is it has really gotten considerably better. I think you combine that with our ability to do kind of safer operations. We've really extended the types of operative procedures we'll do in the setting of metastatic disease. When I was a resident, if you had liver disease, it was really kind of a death knell. Now, if you had one liver met, maybe we'd resect you. But, just the other day, we did an operation where we took out multiple liver metastases, and I did a simultaneously colon resection. And we see those patients living really quite long now, if not curing some of them.
Well, let's switch to rectal cancer. And you kind of already mentioned it, but I want to bring it back to the attention of the audience about dividing the rectum into thirds. There was a lot of discussion about this from a clinical standpoint. You kind of alluded to it already. Could you just refresh our memory, because some people may have just glossed over that previously?
Yeah, so I like dividing the rectum into thirds, kind of the lower third, which would be from the anal verge, which is just essentially the opening of the anal canal, to about 5 centimeters in being the lower third. That would include the anal canal. The middle third would be from roughly 5 centimeters to 10 centimeters, again, measured from the anal verge. And then the upper part of the rectum would be 10 centimeters to 15 centimeters. Those are the numbers I use. Some people might say 0 to 4, 4 to 8, 8 to 12, but I think the concept is still the same. I also still like to look at my valves of Houston, so I think there's 3 distinct valves, usually endoscopically visible, and the first valve really correlates to the upper border of the lower rectum. The second valve is kind of between the first and second, I would consider the middle rectum. And then after the second and the third, you're in the upper rectum. And if you're beyond the third, you're really into the sigmoid colon. The reason that we divide it up in that way is because I think what we can do operatively depends on the location. And also what we can achieve oncologically depends on the location. So I think when we first diagnose someone with a rectal cancer, having a clear idea of where it's located, exactly how far it is from the anal verge, what it feels like on your digital rectal exam, and then well documenting all of that is really critically important so that we can come up with a treatment plan that is unique to that patient. Now, let's talk about staging. Now, you suggested when we spoke about ultrasound that it had been the go-to imaging technique for rectal cancer. But I think we've got a competition with MRI. Is one better than another? Is MRI supplanting ultrasound? Yeah, I would say that MRI has largely replaced ultrasound for the routine use of staging a rectal cancer. And again, when we're staging rectal cancer, I think it's different than colon cancer because we're doing 2 types of staging, if you will. One is locally staging it, and that is trying to determine the depth of invasion, the lymph node involvement, and whether you have what I would call a threatened surgical margin, so that if I were to operate and were to follow the principles of a mesorectal excision, would the MRI predict that I would have a negative circumferential margin? So MRI, for years, ultrasound was what we used for that. It would determine our depth of invasion. It would give us some sense of lymph nodes, but it really wasn't particularly good at predicting these circumferential radial margins. These high-definition MRIs now are really incredible. We can really see the fascial planes, and we can really predict with some pretty good certainty whether we're going to get a negative circumferential margin operatively. It does a pretty good job of the depth of invasion and also the lymph nodes, and for that reasons, I think it has supplanted ultrasound. Now, we also are looking for distant metastases, and so it's still very important to get a regular, usually I get a chest, abdomen, pelvis CT scan as well, and that's the systemic staging. The last thing is, has ultrasound completely gone away? I think the answer is probably no. Ultrasound is still probably better for these very superficial cancers if we're trying to determine if it's just a polyp or maybe it's just invading the rectal wall. And so we still use ultrasound, but we just don't use it as ubiquitous as we used to.
Now, last time we spoke for CSAP Audio and Companion, we talked a lot about neoadjuvant therapy and that it was slowly gaining ground in the U.S. Is it still gaining ground? Has it become the standard of care? Where do we stand?
In my humble opinion, it's become the standard of care for locally advanced cancer. So what exactly does that mean? So if you have a stage 2 or stage 3 rectal cancer, then that would usually involve neoadjuvant chemoradiation. So that's T3 and above or node-positive disease. It can get a little bit more complicated, but I think those are the general guidelines. And if you follow those guidelines, I think you'll be practicing at least standard of care in the United States.
And if the tumor shrinks and disappears, what happens?
So now we're really getting into a much more controversial area. And so I'm almost hesitant to talk about it. But, if you still looked up guidelines, I don't think there's any guideline that would say that we should not operate. Now, having said that, what we have learned and what we are learning is that there are a number of people that if we do chemoradiation, we wait a little bit longer than we used to wait. And now if we follow it up with systemic chemotherapy, that we can do a complete clinical response and really almost as high as 40% of our patients, which has changed the practice in my humble opinion. So what do I do now? I used to rarely do this, but now I reevaluate people constantly. And if their tumors have gone completely away and that operation would involve a permanent colostomy, or for our patients that are elderly and frail, we are following a lot of these people in what we'd call either a watch and wait or wait and watch. And the idea is that you're just very aggressive about surveying them, and that, somewhere around 30% of the time it's going to come back. But if you are aggressive about that surveillance, the hope and the thought is that you can then do the operation that you would have done and that you can salvage that group. But if you happen to fall into the 70% of people that never seems to come back, then you really dodged a really morbid operation. So it has changed what I do.
Let me just be clear. So we're talking about a population that you put them through neoadjuvant therapy, the tumor disappears, and you have a biopsy-proven result that you have a true clinical response that the tumor is gone. Is that where the starting point is?
Not entirely. I mean, so most of the time it's based on endoscopic visualization and also an MRI. And this is why probably the only people that should be doing it are people, in an ideal world in some sort of clinical trial. We were involved in a multi-institutional trial. Unfortunately, that trial is now closed, and we're waiting for the final data. But it certainly should only be done by people who would do a lot of it, because a lot of this is the detection is really on visualization, endoscopic visualization, and really being able to interpret what a complete response looks like. So it's not really based on biopsies, it's really based on the eyeball. And so it takes a lot of experience. That would be the starting point. And generally speaking, there's a very classic looking white scar. It's not heaped up. There's some telangiectasia associated with it. And if you can feel it, and a lot of times you can because these things were in the distal rectum, you really feel no mass. And those are the people that we've been following.
Well, let's talk about mesorectal excision, which you've also mentioned. And have we reached the point that MIS approaches are now considered the way to go? And that begs the issue, is the robot any better?
So I think that is also a bit controversial. You know, the principles of a mesorectal excision is that you really want to be in that perfect plane. And that perfect plane is really defined by millimeters. And in an ideal world, you want to take out the mesorectum and you want to take it out completely intact. I know about 5 years ago, there was several trials that came out, both within the United States but also internationally, which had kind of mixed results. The one in the United States initially looked at the quality of the mesorectal excision. It was a surrogate marker for recurrence. And unfortunately, it didn't have the result that I think some people wanted. And it really implied that perhaps the quality of the mesorectum when you were done was slightly inferior with laparoscopy compared to open surgery. That really hasn't translated into increased recurrence rates, so now it's a little bit fuzzy. But anybody who's done a lot of laparoscopic surgery in the pelvis can attest to the fact that it can be very easy to kind of injure the mesorectum. Now, you know, what I've talked about a lot with my partners is like, you know, if you're in the right plane, but you just happen to injure it just because you grab it in a certain way, does that oncologically make a difference? And I don't think we know the answer to that question. What we have found is the robot is probably, I think, a little bit easier in the pelvis once you've got the robotic skills, and has, I think, opened the door to more minimally invasive techniques. But at the end of the day, I think you just want a surgeon who does high-quality work. And, you know, when I talk to my patients very carefully about this, the size of their incision is really not what they're worried about. They're worried about a good quality operation that's going to limit the local recurrence rates. So whatever you can do best is what you should do.
Okay, now at the clinical congress this year, there was a model for mesorectal excisions, and there's a lot of discussion that maybe that in the U.S. we don't do this as well as our European colleagues do. Do you have any comments about that? And I don't know if you saw the model or not. It was pretty neat.
Yeah, I definitely heard about the model. I did not see it. I think what you're, you know, kind of discussing, which gets to be a little politically hot, as you know, is, you know, there's probably some value to experience, right? And so people that do this operation a lot get better at it. There's no doubt. And people who have done some sort of fellowship training, whether it's colorectal or surgical oncology or some extra kind of training to really focus on the principles of a total mesorectal excision and really understanding what that means, I think we believe have better outcomes. What's happened in our European countries is they really have centralized a lot of rectal cancer care. And so not everybody does it, right? They try to focus their care in specialty hospitals with specialty surgeons, and therefore, quote unquote, have done it better. So there's been a push here in the States, you know, and as we've discussed a little bit, this gets to be a politically hot topic. If we're going to accept the principle that everybody should do everything, then we at least should be making sure that we're training people and also demonstrating that we're doing this responsibly. So there's been really two major initiatives, both through the college. One is that you just talked about, you know, these kind of models to help people learn the principles. But also now there's the national accreditation for rectal cancer surgery, where, you know, you can apply to become a kind of quote-unquote center of excellence. There's a lot of criteria. Truthfully, we have not done it yet ourselves here because there is a lot of paperwork, if you will. But the idea is that you have to kind of prove that you're doing good work. which I think is what our European colleagues have done and what we're trying to stress as our goals in this country as well. The most important thing about this, and we talked about this a few weeks back, it is a teachable concept. And one of the really coolest study I ever read about was the Swedes, quite a long time ago, did a whole series of rectal cancer studies, and they used the same surgeons. And the initial studies, the surgical outcomes were kind of, so-so. And then they actually did a course where they taught the same group of surgeons the principles of total mesorectal excision. They had a 3 or 4 day course. They had world's experts come, and in fact, they had Bill Heald, who's probably the world's expert, come and train these surgeons. And then they redid the trial, and their local recurrence rates plummeted. And that was just with 3 or 4 days of intensive training. So it is a teachable technique, but you have to do it. You have to do it right.
Well, Charles, I think at many of our committee discussions about content that we put in CSAP, we fall back on two things. One is the evidence, but the other is experience. And I think what you've just elucidated is testament to that approach. So I have another question, and it relates to anal cancer. And I'm just curious what you think the NIGRO protocol, which I believe is still what we use, has really stood the test of time. Is that true, or is there something that is now going to supplant it for chemoradiation for anal cancer?
No, I think you're 100% right. I think it has... we use it primarily. Occasionally we'll use cisplatinum as an alternative to mitomycin C, but in general, we still use the NIGRO protocol. And for most of our patients, that's very, very effective.
And I'll ask the same question I asked before about rectal cancer. What about a complete responder? What do you do with them?
Yeah, so for those folks, I think that the expectation is that we're going to get a complete response. And so unlike the rectal cancer, which is not quite standard of care to follow the people that are complete responders, I think for anal cancer, it is absolutely the standard of care. And in fact, the classic tricky question is, what do you do if it's 4 weeks out and it hasn't completely gone away? Do you biopsy it or not? And so the short answer is you probably don't even biopsy at that point. That we know that tumors regress for even up to 6 months. And so I will see folks back 2 or 3 months after they complete their therapy. If the thing is gone, that's great. Then we're certainly going to follow that patient. But if the lesion has regressed considerably, even if there's something that's still there, I will see them back 4 weeks later, and I won't rebiopsy anything for up to 6 months. If they have persistent disease at 6 months, then I think we would consider that a failure of the treatment, which is unusual, and then that person would require operative intervention. But you do want to wait 6 months, and our goal is trying really hard not to operate on these folks. And for most cases, I think we're pretty successful.
Well, let's talk about a topic that I know you were waiting for me to ask you about, and that's the colon surgery bundle. So the first thing I want to ask, have we come full circle regarding preoperative colon preparation for an elective colon operation?
Yeah, I think we have. It's been kind of an astounding journey, if you will. This is one of those cases where I never read like the literature from the 70s, but once we started going down this path, I went back and read some of the original Nichols papers, and they did a good job. And so what happened probably when I was a resident, so what is that now? We're talking late 90s, early 2000s. There was a host of papers that suggested that bowel preparations didn't make a difference. For one reason or another, which I don't totally understand, we got away from giving the oral antibiotics, which was really the original Nichols prep, if you will, back in the 70s. And all the studies that were being done were just using mechanical bowel preps and just, IV antibiotics. and most of those studies did not demonstrate a real benefit. And so we kind of got into this, pendulum swinging where we thought that we just didn't need to do bowel preps. I think there is growing evidence, largely through the work of these large now databases like NISQIP or the Michigan Collaborative as well, that have demonstrated that people who get mechanical bowel prep, oral antibiotics, and their IV antibiotics at the time around surgery have way better outcomes. So we have totally come full circle, and we do the full bore on everybody now.
Well, I'll tell you, Charles, I was a student when the Nichols-Condon study was ongoing at the VA in Milwaukee, and I can tell you walking around with those packets and making sure they got those packets at the right time before their operation was a yeoman's task, let's just put it that way. So it was a well-done study, no question about it.
And it worked.
It did. How do you like that?
Yeah, and I don't know why it took us, 60 years to figure it out, but it's just, I guess it just kind of speaks to, also how, as a profession, how things can evolve in weird ways that we don't really intend, and how you just got to constantly measure ourselves and reassess ourselves and just asking, are we doing the right thing?
How true. So let's talk about the bundle. So now there's pre-op, intra-op, and post-op interventions that are aimed at reducing surgical site infection after colon surgery. Let me ask you your personal opinion regarding the bundle, and is there one part of the bundle that's more important than another?
So I think that we don't know, kind of taking a step back, we first went through all the skip measurements, as you recall, and that was a lot about, not clipping and we were actually not doing mechanical bowel preps for those and getting the antibiotics on time and a lot of different parameters. I think they thought that would be the holy grail, and that if we all just, followed the right processes, that our surgical site infections would all magically go away. And unfortunately, they didn't. Right, so we all got really good at giving the antibiotics on time and following all these kind of skip parameters, and we all got A's for following the processes, and our surgical site infection just didn't really change that much. What has we wrote about that, and I think people ridiculed us for a bit because we were saying we had 20% surgical site infections. And people thought that was awfully high. And then, lo and behold, other people started writing about it, and they said, yeah, it turns out to be right. What we have done is now these enhanced recovery pathways. And that really has changed quite a bit our own personal surgical site infections. We were pleasantly surprised. I don't think we necessarily did it with that intent, but we did greatly limit the amount of IV fluid. We use some carbohydrate loading. We do full bowel prep now. I must admit we changed to a clean closure tray when we close the wounds. We do a chlorhexidine prep, the night before. And we've got a fairly robust system. And our length of stay dropped considerably. But lo and behold, for reasons we weren't really totally sure why, our surgical site infection rate also plummeted. So to now it's less than 10%. You're asking, which is the most important part? I don't think we know. And we're a little bit scared to start taking things away because it's working. And it may be that the sum is more important than the combination is more important than any individual one. And I suspect that's true, that it's not going to be one magic bullet. It's just going to be attention to detail and all of these things put together. But it has worked for us.
Well, that's good to hear. And you mentioned history, so I'll just give you another piece of history from the Nichols-Condon day, and that was one of the things that was always used was a clean instrument tray to do closure. It's not mentioned in the study because that was pretty typical of what everybody did for a colon operation. And so when I think back, as we evolved away from that, it's once again, we've come full circle to go back to a basic surgical principle to use clean instruments as we close that wound.
Yeah, and I think, I give one of our techs credit. I mean, we had a very good surgical tech that we work with quite a bit. But as you know, should go to lunch and whatnot, and then somebody else would come in who we didn't recognize and we didn't really know, and perhaps was less experienced. And she was the one that noticed. She said, you realize, you do an anastomosis and you use that sucker or you use that pickup, and when you started closing the wound, she gave you the same thing back. And we were a little astounded to hear that, but we just decided to take that kind of variable out of it. If we just, brought all new instruments in, then there was no, whatever tech you had that day, that variable got removed. And so that's what we did.
Let me ask you about the reality of colon surgery, and that we do have leaks. And we had a discussion at our M&M last week about the value of an ileostomy after a low anterior resection or a rectal anastomosis. And the discussion was pro and con. How do you stand on that issue?
Yeah, I'm firmly in the pro camp. Anastomotic leaks are the reality of colorectal surgery. I hate to admit it, but I probably have become the state's expert in, anastomotic leaks. I do more colon surgery than anybody in our state, but that also means I probably have more anastomotic leaks than anybody in our state. They just seem to be something that we can't completely avoid, despite, attention to detail and all those things. And that's been, I think, shown over and over again. For rectal anastomosis, there's a lot of variables that go into this. Do I divert everybody? No. But do I divert a lot? Yeah. So it really depends on how low I go. So virtually all of my rectal cancer patients have gotten neoadjuvant chemoradiation, so I think they all get diverted. If I'm doing a total mesorectal excision, then my anastomosis is palpable on a physical exam, from below. I divert all of those. Now, what's my cutoff? Well, if I'm in the mid-rectum, they haven't been radiated, the operation goes beautifully well, their albumin is normal, they're a woman instead of a man, which usually we have some evidence that men leak higher than women. I suspect that's due to some of the anatomy as well. Then I might not divert that patient. But I also, tell them somewhere in the order of 5 to 10% leak rates for those lower anastomoses. The problem is when they leak, the consequences are significant. I think there's some debate about whether a loop ileostomy prevents a leak. I think there is some evidence it does. The flip side of that is that what it definitely does is prevents the significant sequelae of a leak. So if somebody does have a leak, then you may not even know. And they don't tend to get reoperated, and they don't tend to get sick. I am a big fan of it. I use a lot of diverting loop ileostomies in my high-risk patients, and I guess I favor it. What was the consensus at your M&M?
Consensus was that the pros won, and just for the reasons that you say. What was an unanswered question is, how long do you wait before you close the ileostomy if everything looks great?
Yeah, so we don't have a really good number for that either. Historically, I guess, if I'm going to say that, early in my practice, again, most of these patients were rectal cancer patients, and a lot of them went on to get systemic chemotherapy, and I would always tell them to do their systemic chemo first, so it would be frequently 6 months before I was reversing them. But that had nothing to do with your question. That just had to do with the treatment of their disease. In general, I usually wait about 8 weeks before I study it, and if it looks okay, I try to take it down 4 weeks or so after that. Probably we could do earlier, if you want my humble opinion. It's probably either healed or not healed much sooner than that, right? So there are circumstances, for one reason or another, where a patient's not tolerating the ileostomy, or they got an obstruction or this or something, and I'm going to have to do something with the ileostomy. And I have studied those people even at 2 weeks, and if it's normal and the answer is to get rid of the ileostomy, then I've taken it down even earlier than that.
let's move to inflammatory bowel disease. And the question that seemed to come up in CSAP-17 was the effect immune therapy for UC has on surgery for UC, and has it altered the need for surgery? That was kind of the question. Do you have any comments?
I think it probably has. When I was a resident, I remember, it was pretty common. We had 2 or 3 people in the hospital we were following very closely, and we were doing a fair number of kind of urgent, emergent operations, and I just don't see that as much anymore. It's pretty rare that we have to do a true emergency operation for toxic colitis now. We do some urgent ones for people who are just not improving, but these really kind of emergent things, I have to admit, the numbers have really dwindled. And I think it's because our GI colleagues and their magical medications are doing a better job of controlling the disease.
And when we're talking about UC patients, they're obviously high risk for colon cancer. What's the proper surveillance for them?
Yeah, so those folks are high risk. Certainly after about 8 years of disease, they need to be surveyed for colon cancer. There are a couple different techniques that people can use. We have traditionally done kind of random biopsies where they have taken 4 or 5 biopsies every 5 to 10 centimeters. I think you want to get a total of somehow in the mid-30s, total number of samples, if you will. That is a random process, and you're looking for evidence of dysplasia. And if you have evidence of that, then that would be an indication to actually do a proctocolectomy. I think what's evolved now is something called chromoendoscopy, where our experts, our GI colleagues, are using dyes to kind of bathe the mucosa in a dye. And what it does is that this quote-unquote, these things that we thought were invisible tend to become more visible, and that they're doing now less random biopsies and more directed biopsies, looking for these areas of dysplasia. And that's really critical if we're going to save these patients from developing colorectal cancer over time.
Okay, now you mentioned proctocolectomy. Is that the proper operation today, or are we still trying to salvage the rectum?
So it depends on what indication you're talking about. If it's ulcerative colitis and either you're operating for their inability to control the disease with medication, or if they've got evidence either colorectal cancer or high-grade dysplasia, the answer is still total proctocolectomy. There are some rare instances where you might try to preserve the rectum, but I think that's the exception and not the rule.
And is Crohn's approach any different?
I think we used to say that the Crohn's colitis didn't carry the same risk as ulcerative colitis for cancer. I don't think we believe that anymore. I think there's pretty good evidence now to suggest that people with Crohn's colitis also carry a fairly high risk of developing colorectal cancer. So I think it's important that those patients also get surveillance. In general, the approach is similar. We're a little bit more willing to do segmental resections in Crohn's disease because we are not curing their disease, and sometimes the disease is limited to just parts of the colon. So we're a little bit more interested in rectal preservation if the rectum appears to be normal. They are not candidates for J-pouch reconstruction, so if they require a total proctocolectomy, that's going to be almost certainly an endoleostomy. And so those would be kind of the largest differences.
Well, goodness gracious. Time has flown by this morning. Charles, I've really enjoyed talking to you as usual. I learn and clarify a lot of things with each of our discussions, so I really do thank you for that. And as we come to a close this morning, I'll just ask you, do you have any comments about CSAP, the process of how we develop CSAP, or CSAP-17 audio companion? The floor is yours.
Well, I think that CSAP has been a product that I've used, since I was a resident. I don't know how many versions of it is at this point. We've talked about this quite a lot. There is an evolution of how it's going to be used. I will fully admit that I frequently used it in times where I was studying hard for exams, particularly either the qualifying exams or subsequently when I was trying to do my maintenance and certification and whatnot. With the changes, the needs for CSAP, if you will, has changed. But what hasn't changed is the educational content, right? So the motivation might be different, but the tool has been incredibly important to me, especially in someone who went down a specialty path. I am a general surgery program director. I try to stay up to date as best I can in the other areas as well, and it's a very efficient way to get my educational content. I think the other thing that does a nice job is it doesn't just stay to the really basic stuff. It's willing to explore some of the more controversial stuff. And it may not be the stuff that's going to show up on an exam because it's a little too controversial, but that's what keeps us up to date. The CSAP Audio Companion, I remember once listening to this, and you were interviewing John Hanks on some endocrine topic, which I hadn't really thought about in a long time. And I was driving down to my testing center, and I listened to John Hanks talk about endocrine for 45 minutes as I got to my endocrine session. And thank God I did, because I probably got 3 or 4 questions right because of that discussion that I wouldn't have gotten. But it's really great to kind of hear you interview people and hear their opinions about all these topics.
Charles, thank you very much for your contributions to both products, and I'm very happy that we could arrange this discussion this morning, and you have a great day.
Yeah, you as well.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.